Next, I'll be talking to you about central retinal artery occlusion.
So Dr. Rahul is working at Chaitanya Eye Hospital, Palarivattam, taking care of the vitreoretina department.
So, may I have the slides, please. So, very good morning. At the outset, I would like to thank Dr. Sanjana for this wonderful invite. So, central retinal artery occlusion is analogous to an acute stroke of the eye. The most common cause is embolism. This emboli may be a cholesterol, calcific material, or fibrin. Not just the embolus, sometimes even an occlusive thrombus just immediately posterior to the lamina cribrosa might also cause a CRO. So, CRO might be either a non-arthritic or arthritic. So when we talk about arthritic CRO, we are basically concerned with giant cell arthritis. The treatment for that is mostly steroids. And in non-arthritic, it could be either a permanent CRO or transient one when many of the times a patient comes to us with history of TIA, and it could be a CRO with ciliaretinal sparing. So once you see a patient of CRO, rule out arthritic CRO. For that, you require an ESR, CRP, and platelet. Then look for the vascular causes like check the blood pressures, fasting lipid sugars, and blood lipid profile. If you want to look out for the embolic source, you can do a carotid ultrasound or an echocardiogram. Young patients look for hypercoagulable states like looking for the protein CNS, factor Leiden mutations, and APLAP. For the if you want to rule out the vasculitis, you have to do an ANA, ANCA, or ACE. Also, try to make sure that you're missing a case of myeloproliferative disorders. So, get a peripheral smell and HB electrophoresis in these patients. Now, the management of CRO could be broadly classified into three types: acute, subacute, and long term. The acute and subacute management, the treatment lies with us as an ophthalmologist, and the long term treatment is with an intensivist. So, the acute management is basically to restore the ocular perfusion to the central retinal artery. The subacute treatment is management relies on preventing secondary neovascular complications, and the long term is to prevent vascular ischemic events to the other eye or probably other end organs. So the acute management is the standard therapy that we usually follow is you start the patient on, you can give sublingual isopropyl dinitrate or systemic pentoxifylline. You can give even inhalation of a carbogen or hyperbaric oxygen, ocular massage either with the lids closed or with the gonio lens, and acetazolamide and mannitol with AC paracentesis. A key point to remember with the paracentesis, like unlike in the surgery when we do a gradual one, here the paracentesis should be rapid. The goal is to create a sudden decompression, okay, and or most of the times you have to use a combination of this therapy. Thrombolytics has a very good role. So the ideal golden time is about 4 hours to 6 hours. So it could be either an intraarterial fibrinolysis or an intravenous fibrinolysis. So for an intraarterial, basically the cannulation is done in the ophthalmic artery, but the problem is you require a very good interventional neurology setup for that. It can also be administered intravenously, but the good thing about that is that the hemorrhagic complications are actually less. Now, the subacute management is to prevent the development of neovascularization and neovascular glaucoma. Now, the prevalence of seeing neovascularization happening in a case of CRO is very debatable. Literature states about from 2.5 to 32% cases can develop neovascularization. The ideal time is the range when they can actually develop is about 2 to 16 weeks. So ideally, such patients, when you see, like if you see, unlike a case of CRVO, where the chance of neovascularization is very high, CRO, the chance of NVG happening is very less. So ideally speaking, so probably up to 4 months, you should be ideally looking for the development of any neovascularization in such cases. Now, before I come to this case, since we have few audience today, I would like to ask a show of hand. How many of you have seen a case of CRO? We always tell, we always blame like the patients. Like most of the cases of CRO, we get to see them after 1 month, 6 months. So probably it's a lost cause. So show of hand, how many of you have seen a case of CRO within 30 minutes? Anybody over here? 30 minutes. How did it go? The management. No. I know the management. I'm asking, how did that end up for the patient?
Patient had some vision, definitely. The patient ended up having 6/18 vision.
Okay, so you managed conservatively.
Yeah.
Okay, so I had a very bad experience. Like during my fellowship days, I was in Shankar Netralaya. So there's this patient who came to us who had already lost his vision in one eye to CRAO. He had underwent multiple valvular heart surgeries, and he used to stay very close to the college road where Shankar Netralaya is, because most of his follow-up was at Apollo Hospital, which is in Greens Road and SN. So he developed lost his vision in CRAO in right eye, developed the symptoms. He was already advised from here that the moment you develop some symptoms, you take a paper bag, start the paper bag ventilation, and then come back. He reached to us in 30 minutes. We did everything what we had in our armamentarium. We did the gonium massage, we gave mannitol, AC parenthesis, everything. Finally, it was a lost cause. So, that was the one time when, I was wondering, like anything, literature, we give all this treatment, but all this treatment are up to chances. Because even when we send the patient to a, intensivist, their treatment is usually a guarded approach to prevent this further probably stroke or something like that, rather than intervening for the CRA, central retinal artery block. So this is one I would like to acknowledge my senior, Dr. Jaydeep. So this was an 83-year-old lady who came with sudden painless loss of vision in her right eye of 4 days. The vision was hand movements. The left eye was already lost because she had a total corneal opacity. She was blind in that eye. So this was the fundus picture. You can see a retinal artery sparing CRAO. So finally, he had to do something, especially to get fitness for surgery in such cases is very difficult. So he subjected the patient to vitrectomy. So I'll just show the video here. I'll just run through the steps here. So this is a normal vitrectomy that's being done. So we do something called as a hypotenuse vitrectomy in such cases. So initially there was no PVD. So IVT was used to stain the vitreous, and a PVD was induced. And we try not to do a complete vitrectomy, at least till mid-periphery, the vitrectomy is done. And then with a soft tip cannula, he's doing compression over the central retinal artery. He's trying to milk the embolus away from the central part and to the periphery. After that, he has used an MVR blade to kind of dissect the common adventitious sheath. So what happens is the central retinal artery and the vein are encased in a sheath, and he's trying to dissect it with an MVR blade. Okay, so you cannot do it completely, but at least some amount of it is being done. And then whatever bits of tissue that is left there, it's been taken up by using an end gripping forceps. And finally, again, with the cutter tip, gentle pressure is applied over the central artery to kind of dislodge it. And then what it has done is he's doing a fluid air exchange. Okay. And like I say, when we start the vitrectomy, the pressure is around, usually when we do a vitrectomy, we keep the pressures at around 25, 30, depending on what case we do. But here, the pressures are kept at 5 to 10 millimeters of mercury column. Okay. And finally, he has used a FAX and replace the entire fluid in the eye with air now. And then you create sudden fluctuation IOP. You increase the pressures from 5 to 60 and then suddenly put it back to 5. So you want to decompress the globe multiple times. Okay, it has its own risk and complication, but that is the only thing that we can do here. So finally, so just like I said, the IOP is done is called something called as hypotenuse vitrectomy. So the pressures are done at the range of 5 to 10. PVD induction, so many times you might see the PVD is already induced. So the thing is, the logic here is, this vitreous is very attached to the blood vessels. So when you lift it slowly, it's kind of milking the vessels. And then try to dissect the common adventitious sheath, massage the central retinal artery, and repeated IOP fluctuation. Now, we can do, like when you do vitrectomy, we can reduce this fluctuation of the IOP with the fluid as well as with air. But what happens is, because of surface tension, air has a much more better tamponade effect. So that is the reason FAX was, like the fluid air exchange was done, and then the IOP fluctuation was done. So this is the final outcome. This is the pre-op picture and this is the post-op picture. The vision improved from hand movements to 6/12. So also one more technique that has been done, reported in literature previously, is like they do a vitrectomy. They kind of, since the retinal artery is already occluded, they kind of make a small nick in it, and using a stillet, 51 gauge stillet, they kind of try to recanalize it. But the problem with what happens is the very variable results. So vitrectomy is one thing which we can keep it in our mind. The first report, like not report, like very few surgeons actually do it. Dr. Mahesh Shanmugam was the first person where I heard, like, vitrectomy can be a option for it. He had operated on a doctor actually. I think sir might be knowing that case. As a doctor, he had operated. The patient finally ended up getting 618 vision. There are few surgeons who are still doing vitrectomy. Like for my bad leg, I still haven't got a case where I could try this. But vitrectomy does definitely have a role, and the time frame is very debatable because we don't have much large case series about doing a vitrectomy for such cases. But the general reference that we take is up to 1 week we can actually take such cases for vitrectomy. So the take-home message is CRU is an ocular emergency. The risk factors that also predispose to cardiac, peripheral, and CVEs. So the moment the acute management is done from our side, you have to send such patients to intensivist, and that is the most important message I would like to give. Thank you.
Thank you, Dr. Rahul. Any questions from the audience? So, thank you for informing us that all is not lost. We still have a vitrectomy option in such cases.